job, Jane. And then we are going to do this screen. Oh, look at that. Yay. Okay. So, no office hour this week because we have lecture, no office hour next week because we had lecture. So then, it won't be office hour until the following week. And we are doing 1 hour every other Thursday at 8 still for the summer. And we only have 2 more units until the skills weekend. So 1 unit is 4 weeks long and then 1 unit is 2 weeks long. So there's probably only gonna be like 1 or 2 office hours in there total. Any questions about the things that were clarified about the skills weekend? Start times, dates, travel times that we're trying to build in. Anything like that.
I have a question.
Yeah.
My question, what can we anticipate as far as skills?
Bedazzling and fabulous sprinkles of knowledge. No, I'm joking. Pretty much, we're gonna go back over everything and all the topics, and we're gonna do the hands-on portion of all the topics of the units. Okay, we'll do the hands-on portion for the built-in certifications. So you'll get the last components of the fertility and conception counseling, birth doula, postpartum doula, lactation certification, midwifery assistant. It's all the hands-on aspects. We'll do some hands-on charting practice. We'll do some palpation practice. It's all the hands-on aspects that are gonna go with the units that we have done didactic education.
That's exciting.
Okay. Is that helpful? And nothing, I mean, nothing new in the sense of like, it's not going to be a topic that we haven't already covered. It's the hands-on portion of everything that we've covered. All physiological units. We will be switching platforms after that, but we'll be ironing that out. We're gonna keep using Teachable up until the skills weekend, and then Auntie wants to switch to a different platform. We're probably gonna be in Google Classroom. So that will be happening, but we'll have that all worked out by the time we come, because we'll have a break. We'll have a short break after the skills weekend, and then we'll get back into everything.
Well, that's exciting.
We'll be getting the rest of the books for the last 2 units to take us up to the skills weekend. And if you chose to purchase or did receive a Myers text and pocket reference, please let us know that you have that one. And if you don't, you will be receiving a copy of that one. It is, Auntie put a picture of it. It's a supplemental text because it's one of the texts that we had been debating about when we were thinking about our book list, and it didn't make the final cut, but it is a super, super, super awesome reference resource. And if we all have it, then actually I'll probably incorporate it when we go back into anomalies and concerns. Is that everything? I think that's everything that I meant to cover. Any questions?
Should we bring anything?
Other than the things that Auntie had said to bring, it's up to you how much of your textbooks or your notes, whatever note system that you have created for yourself. You will be receiving some resource books. But as far as, you know, however you're making your note binders or your own study materials, that's up to you. And it's up to you which one of your textbooks that you want to bring. If there's anything that's tested on or skills tested on, you'll be provided with those materials, or you'll be given enough notice that, hey, you know, make sure that you bring XYZ. No pop quizzes. Eh. Anything else right now for about any of that?
I have a surprise for us.
Dude. Oh, this man is getting molars and he thinks it's really funny to just rip himself off because it's really fun.
Ow.
Okay, otherwise, let's do open discussion of the readings for this unit. Who wants to? Okay.
Was
Mike.
there a surprise?
What's that?
Dr. Jen said she had a surprise.
Yes, I do. It's very exciting. And it's a 2-day opportunity to totally go, oh, that's kind of cool.
During the skills weekend, right? That's what you're talking about?
Yes, I am, October.
Okay. I think
Sorry.
everybody was like, well, what is it?
I don't know. No. The operative word is surprise.
Yeah. Yep.
Okay.
You're no fun.
I know, I can be though.
No, I'm teasing. Get it out of her, Jane. No.
She actually knows a piece of it.
Oh, okay. All right. Well, we'll leave it alone.
Okay. Okay, so who wants to start us about the readings for the unit?
My question to the students on the readings would be, would anybody be willing to reflect on how the pace and the mount is going for you, so to speak?
Everybody's quiet.
Yeah.
Start us off then, Shoshana.
The pace and the amount.
Or one of the topics.
Okay. The pace and amount. Well, I'm just a busy girl anyway.
Right.
You are.
um, I have some late nights, and
Yeah.
I you know, it's really good information, and I know it's really important information.
Hmm.
But I'll give it the like quick peruse through it and get the gist of it. So yeah.
Hmm.
And I've heard before, like we'll get the information, we'll go over the information, we'll cover the information again. So
Hmm.
and that was kind of the question with, well, what's going to be covered with at the hands-on? Will this help us too? With the hands-on with some of the stuff that we're reading now.
Well, I just want to say there that a reading strategy wise is to get an overview and then, you know, maybe take some places you have questions about, or if any of you are visual readers or visual learners, to once you get into the skill session to say, oh, that is something for me to come back to. To, you know, to feel the significance and the importance because it is being layered on, so to speak.
Mm-hmm.
I don't know if that makes sense, and I hope I'm not rambling. So I guess reading for an overview, if that's a strategy, because there's so much or too much, or you're not clear what's really important to dig in deeper, that's actually a good strategy, is reading for an overview.
Yeah. And I'll just say, I don't know everything, but I know some things. And I'm not a doctor. But I
Well, it's a good thing that's not the goal.
know. I guess
So-
maybe we can start on like, you know, like newborn assessments. Or no,
Well, anything from like the sections in holistic midwifery, you know, the reading sections. This is just about the read what you were reading in the books. So there was some sections in holistic midwifery, care of the well newborn, 2 chapters in there, Varney's, a couple chapters in there. A few of the chapters, you know, we've already visited sections in those chapters. And then a couple portions in healing passage.
I like the newborn book. The I can't remember what it's called because it's like over there and I don't want to move to get it, but
care of the newborn.
that was nice.
That's where I was trying
newborn
to
book,
go
yeah.
to.
Yeah.
Yep.
But
Care of well
in
newborn.
all honesty, I'm ready to set Varney's on fire.
Okay, that's fair. That's very fair because it is written for CPMs and CNMs. It's not really written for DEMs. It's fair. And we it's one of the reasons why we debated between that and Myers. Varney's is still professionally referenced as kind of like the go-to gold standard, you know, and part of it is we're setting the standard of, okay, here's my pen. You know, setting the standard of what's the professional peerage. When you walk into a peer review and they're talking about Varney's this and Varney's that, and you know, we don't want to set you back by never having you crack a Varney's. And there is definitely several sections of Varney's that I just want to rip out of the whole dang book. So that's a solid and legitimate, like, yep, we're over Varney's, like, that's a legitimate feeling, and I feel you on it.
But I mean, to be fair, like the parts that I'm going over again, like, so what I did when I first read it, I marked or I highlighted stuff I either didn't understand or stuff that I went, oh yeah, okay, that like did something for my moment, like a aha moment or whatever. And then now I'm reading it again, and some of them I'm like, oh, okay, no, I know what that means now. Like I have a better idea what that means. And some of them I'm still totally clueless about, but it's not so bad. But I like the
Nice.
newborn book. I like the way she wrote it. And the language that she uses. I like that one.
Okay. My only other thought about Varney's is like, we're not trying to pigeonhole you into practicing within the realm of Varney's. We are giving you the whole information base, and use it, don't use it, never touch it again, throw it out the window. Okay. Don't incorporate none of it into how you personally practice. Okay. It's, what's the thought? Sorry, guys. It is still a professional, it's very heavily professionally referred to. It's part of the literature that we may or may not get compared to, especially if we're in a transfer situation. So that was a lot of the consideration when we're like, do we even want to include this? So feeling frustrated about it and feeling like, you know, yes, this is just another literature that is completely written for middle-class white ladies, because it is. That's who it was written towards and about, because that's who they were taking the time to research, you know. And I'm not trying to say this as like it is what it is, but we're not trying to like turn out a bunch of Varney worshiping DEMs.
Yay.
There's the thought. Okay. How about the state paperwork process? Like, how did that go for you guys? What did you learn? You know, what were you surprised about? How easy was it? Does it feel helpful knowing where to find it, how to find it, like all that?
I went down a long rabbit hole after the information that I found because I kept clicking on more stuff, and so I found like more information about this the state and the scope of work for midwifery and like whole little like I don't even know what to call it. I feel like I want to say like it reminds me of looking at like our articles of incorporation, but so like like what can and cannot be done and like for the whole state. It looks like if official like documents that I found just from clicking on one different thing and it just like I had literally like 8 tabs open look at it and I was like, okay, too deep, Shoshana, answer what they're looking for. But yes, I found the information. I feel like I answered what was requested. Very good information. I talked about like, you know, if parents weren't married. I talked about a form a midwife needs to fill out and complete. If they're going to be, you know, like I can't. I'd have to look at my drive here. A form they need to complete before. Where the hell is it? Midwife in my drive. Opening it. I don't open. Oh my gosh. Somebody continue on. I'm still looking for my my forms.
I thought it was helpful to know where to go to find the forms. You can download them for Minnesota. And it was helpful to know like kind of where to direct parents to if they're like just give them a starting point, right? It's good for them to know that information too and find out all the details that they need. Yeah, so like there's a lot more forms if the parents are not married, which I found really interesting. And just the different ways, yeah, the different ways you can
Oh yeah, I know that one.
Like has her
register, I guess, or the requirements for registration as midwives in the state of Minnesota. You know, registering a birth, and I think those are really good things to know, especially since we're going to probably be doing mostly home births, which are different than home birth center, hospital births. And yeah, I just found that I was probably doing the same thing Shoshana was, with like all these tabs open. I'd read and then there's like a link there, and there's more to read. So yeah, you'd think it would just be like one easy form, but like there's multiple
Yep.
multiple forms, and it's a multi-step process.
Yep.
Mhm.
Did anybody come across there a different process for unassisted birthers? So, for example, North Dakota did a really interesting thing with the COVID pandemic shutdown. They used, and it's an unregulated state, and they used to have it where you could just go to the Department of Health website and print off the PDFs. Like I printed them off. Any parent could print them off. But they were having a lot of during the pandemic, they were having a lot of families walking into the ER saying that they were under care of a midwife, or a midwife's signature was questionably showing up on some of those forms. And now they changed it. You can't pull it down off of the state website anymore. And they passed a state resolution. There's a whole separate process for unassisted birthers to go through to be able to file their own birth certificate paperwork now. That anybody else run across something like that?
Not me.
Did you find that in your rabbit hole? Do you need to go back and see? Because so prior to the pandemic, I did have a few families reach out to me because they didn't know the process, telling me that they want unassisted, but they don't know the process. Do I have to sign it for them? And now it's a different conversation than it was prior to the pandemic, but and which is kind of interesting for an unregulated state. But anything else that anybody wants to share about that process, or any of the reading topics? Or
So can I ask a question then? Coming out of COVID and the switch in the process and the forms, who benefited or who's blocked, so to speak? I don't know why I'm saying so to speak today, but that's the fourth time.
well, so my signature was showing up on a lot of paperwork, and the state was like, hey, this doesn't really look like your signature, and we're having a lot of people showing up at ERs saying that you dropped them off at the door.
Oh my God.
And I was like, yeah, that's definitely not my signature, and I don't know who that family is. And I'm not trying to say like I was the cause of this, or I don't know if other midwives' names were popping up, but of course they're only going to tell me about what my name's popping up on.
Oh, wow.
So, I mean, in a way, it was beneficial to my reputation that they were seeking out this clarification. Because some of them are not not great situations that these families were walking into the ER for. But yeah, it is more restrictive. It is a different process. It's a more complex process because now they have to have a proof of pregnancy, and their timeline is different for unassisted birthers and birthers that I support. So, there's, I don't know if it's necessarily benefits so much as like, it's an interesting move for a genuinely unregulated midwifery state.
Got it.
Okay, we got a
Thank
couple
you.
more minutes. I'm gonna squeak that whole 20 minutes out. You guys know it.
I had to go back and look at it, but because I tried to do Ontario Treaty 3 and the lady was just, she was really nice, but she wasn't very helpful. So that's going to take me a little while to figure out. But so I did Minnesota, and then I found on Minnesota Department of Health, it
Mhm.
had a worksheet of filling out a form for your child's birth if you didn't have anybody help you. And it went through step by step what you need to do. If there was two parents, if you weren't married, if you're like all this stuff. And I thought that was really nice. I hadn't seen that anywhere else. I don't know how great they are at accepting that form, but it was nicely laid out.
Cool. Yeah, it would be if you ever it'd be really interesting to see the difference in the paperwork process across the medicine line, like to see what it looks like. Okay. I'll let that last minute slide. Joking. Okay. So into the unit topics. Okay, so newborn exam. So if you're thinking about the sequence of the units, some midwives will do this before they initially leave the birth space. Some will do it at the 24-hour visit. I don't personally know of any that will do it at like a 48-hour visit, but I don't see why you couldn't. It's usually the family, of course, because they want to do their announcement and like, this is what baby weighs, and like, so it's kind of more, the time frame tends to be kind of more driven because the family wants to have all baby stats. But so that being said, we had talked about it in the previous unit. So let's do a teach back. Who wants to jump in start us off about what could be included in how you structure your newborn exam? What are some of the things that you might look for, might include? What are we looking for? Like, what is the newborn exam? What's the purpose?
I'll just ramble off.
Sure.
So a newborn exam, going back to my old EMT paramedic days brain, checking for airway, make sure airway's patent, breathing, check the breathing, make sure breathing's how they're breathing well, color, look at the color of their skin to see if they're getting good perfusion, tissue perfusion, going from head to toe, looking at their fontanelles to see how well hydrated they are, checking their pulse too from up there. Looking at maybe going down also as well, looking at their umbilical cord and to see if it's still attached, to see if it's done pulsating, checking for that, to see if it's done absorbing or getting all the blood from the placenta. And then checking the chest, we're looking at the breathing, going down, checking the genitalia, boy, girl. A quick overview there, going down to the feet, and then the reflexes, checking reflexes. So the various reflexes there, and then What else? Golly.
Anybody else wanna add to this? Yeah, jump in, guys. Anybody else want to add to this?
Eyes, looking at the pupils, if they're able to follow the voice of parents, looking at, you know, the shape, the of the eyes, are they symmetrical?
So-
Nose,
So
I
I just want to jump in. Reactivity and following is not in. So we're doing like, this is like the first couple hours. Like that might be
Okay.
something as kind of things come online, like auditory reaction, you know, stuff like that. And they might not respond by opening their eyes and looking yet, because we're still talking about like the immediate newborn. Okay, so that could be something that if you could incorporate at like a 1 week or a 3 week and a 6 week to as a visual check of hitting newborn development markers. But that might be a tough one for the immediate newborn.
Would
Sorry,
it be
go
like weight and height and
Yep. Height.
sound, like how they're crying or the noises they're making, or?
Yep.
And I've seen nurses measure their head. I don't really know why you're measuring their head, but
Yeah.
I've seen them get their
Yep.
head measured.
Yep. So the head to chest, abdomen is included sometimes to hip. They're looking for a ratio, because if the head is like say let's like the head is like a 15, but the chest is like a 13, and then the hips are like a 12. That's not a very even ratio. That could be something about either developmentally, or that could be a sign, a metabolitic, because babies' growth ratios are not even. So that can be when those growth ratios aren't even. It could be something that you might want to suggest if they're not decided about establishing pediatric care. Because most of the time what you're looking at is like a pretty even ratio. Like the head to the chest to the hips is going to be usually within a quarter, eighth of an inch of each other. Okay, so if you see something like a 17-inch head circumference and then a 13 and a quarter chest circumference and then a 12 and a half hips, that's a huge ratio difference from the head to the rest of the body. Immediately my mind would kind of go to like, was this an IUGR? Is this baby gestate, you know, next step would be gestationally aging the newborn. So you're looking for a nice symmetrical ratio. Okay, and then so on the last lecture there was other images. So this is a different kind of flow sheet that has considerations of things to look for or measure with the newborn. So I just went with a different image just to expand your database of imageries. So top down, head circumference, scalp color, any bruising, any swelling, is there a capit, was there any trauma, the overall wellness look of the baby, does this look like a healthy infant, are they a smaller head and then barrel chested or very bulbous in their abdomen, you know, then even though we're focusing on physiological normal, but that's why that ratio, that comparative ratio, gets used. Okay, any questions or anything? Because we did, when we were talking about last unit, we did go over newborn exam. Then anything come up in this unit's readings? Anything that you guys want to focus on more about this one? Okay, so I choose to have a single separate sheet. Where is my sheet? Oh, here's my newborn exam, where I just This is an additional sheet that I include in my chart, and it just goes right down the line. Head, chest, abdomen, hips, length, temperature, height, then chest sounds and all the quadrants, gastrointestinal sounds, you know, within normal limit in those quadrants, genitals, developmentally within normal limits, all structures visualized, you know, reflexes, hips, particularly for the girls. We had talked about that in Unit 9 lecture, looking at the spine, the preliminary CCHD, because the official, and we'll get to the 48-hour CCHD too, and why the differentiation is important. Developmentally appropriate for gestational age. Does this 30, you know, if this is a 41-week baby, does this look like a 41-week newborn? You know, and then actually, I don't gestationally age all babies, because like, if this is a 41-week baby and it very much looks like a 41-week baby, like, you know, I don't need to go through the whole chart to gestationally age. But if I'm like, you know, this, we thought your dates were 41, but you know, I can't, this really just looks like a 37-week baby, then I might expand on that, and we will get there too. And then APGAR. So this is what mine, and I'm happy to post this. You're welcome to use it. You're welcome to change it. This is what my newborn form looks like, newborn exam. Because I don't have online charts. It's not practical for my practice right now. Okay, and then
So
this is just another, go ahead.
I was just gonna ask, so then if you're looking at normal GI, what kind of sounds are you looking for or listening for?
So that's one of the things that we will be doing in the skills. That's a hands-on practice that we will be expanding on in the skills.
Nice.
And really, so really the biggest thing for abdominal sounds is that you're looking for no drastic abdominal sounds. That's the easiest answer. Which is kind of a funny answer. But and that's, like I said, that's the skills portion that we will be concentrating on. So we'll be going all back through all these topics and then talking about, you know, what does it actually look like to get a newborn to do the step reflex. You know, we'll be doing all the hands-on portions of that. Right? What was that? Did I miss something? Oh, maybe somebody's mic is open. Okay, so then assessing for gestational age, this is straight from our textbook. And like I said, I don't do this for every single newborn. Okay. But if I have SGA concerns or IUGR concerns, or you know, gestationally and conception window, we were very confident that this was a 40-week baby, but this definitely doesn't look like a 40-week baby, then I would probably go through aspects of this. But when I was a baby midwife, I would have gone through the whole thing. And that's how, again, that's just how your practice will develop too. Okay, did everybody come across this in the text, in the readings? So we're at least a little bit familiar that this isn't like a brand new image. Okay, so that being said, we're gonna practice with some pictures. A few of these, I know the gestational age because I was specifically looking for examples. But really the point of this is that same with APGAR, it's not exact. There is some objectiveness in the skill. This is the art and science of midwifery. Like, it's not a cookie cutter measurements.
Subjective.
Oh yeah, objective. What did I say?
No, you
Objective.
said objective. It's subjective.
Oh, sorry.
Subjective to my discretion of what I'm looking at
Yep.
a little. So not, yeah.
So, if I, and again, like how we practice the APGAR. Okay, if I said that this is a 39-week baby, how do we? Somebody say, do you think I'm right? Do you think it's possible that this is a 39-week baby?
I say even like maybe a little bit younger, but that's just because for me, Nietzsche babies are always like a little bit bigger.
Mhm.
But yeah, I'd even go like maybe 37, 38 with that one. Just by size and stuff. And they're really clean.
Okay, so good point. So actually, aside from this baby was clearly born in the water, okay, probably not overly wiped down. I would actually say that the opposite, the lack of vernix and the lack of the little baby hairs, now I can't think of the word off the top of my head. Vercosa. This baby actually might gestationally be closer to like 41 weeks.
Mm-hmm.
Okay. Nice roundness of the face. So I would say definitely later than 37 weeks because this baby's had time to build brown fat. And for most babies, that doesn't start until 38-ish weeks. Okay. Now, in comparison to this baby, if I told you this was a 42-week baby, how would you feel about that?
I can see the difference in like the arm, like how chubby one arm is compared to the other.
Yep. Okay, you can still see, I mean, very clearly you can see lots of vernix. Okay. You can kind of see the baby hairs on the face. And those usually don't, for most babies, those don't go away until 38, 39 weeks. Okay. Not a lot, and just like you said, not really filled out arms, pretty creased up arms. Okay. Creasing in the back. Not a lot of brown fat of the between the shoulders. Okay. So if I said, oh yeah, my baby was 42 weeks, I know I'm 42 weeks. I'm freaking out. Like I want my baby because I know I'm 42 weeks and then baby comes out like this. Would you like, oh yeah, that's totally a 42-week baby. Now, if it is, and we're not going to get into the what ifs because we're still doing physiological normal, but this would be more in line of a physiological normal 37-week baby. And this is a 37-week baby because it's one of the things that I searched. It was like 37-week baby. Okay. So yeah, really 2-week difference here. A lot happens in that 2 weeks. Okay. Now, look at this baby. Okay, still lots of vernix, but look at how much this baby's filled out. Not creasy arms. You can see the roundness of between the shoulders, so a lot more brown fat. Okay, nose skin creasing in the shoulder blades, right? You see that's a filled out arm, right? Definitely filled out face. Right? Okay, so what about this one?
I'm driving, but the baby looks more petite than its head size. So I would say like 37, 38, maybe even less.
Mm-hmm. Yep. So this one is 36. I did specifically look for an image of a 36-week gestation newborn. Okay. But yep, like this one, the ratio, very helpful, pretty quick, you know, pretty, once you see them all side by side, right? Like now and this is where the finesse and the art of like, yeah, that, you know, okay, if she spontaneously went into labor at 36 weeks, I would expect to see a 36-week looking old baby. I would not expect to see this this little guy coming out. Right. Okay. What do we notice about this one?
He's got a roll in the back of his neck.
Mm-hmm.
He's just cute and chubby.
Mm-hmm. Yep. Anybody want to throw a number out?
I'm gonna go for 41, 42.
Okay. Yeah, that's totally within reason. Yep. Okay. Anybody, how are you feeling on this? You want to go over anything? Now, looking at those babies in comparison to each other, now, does this chart make more sense too? Right? Now, even like, so the angles that they're saying, how to score it at the bottom. And there are some midwives that go through this with every single newborn. And if that's what you want to do in the beginning or always, like that's your style. Okay. Establish breathing and circulation changes in the immediate. Okay. What's going on? What are the big shifts? Someone start us off. What starts this shift? What has to happen for this chain reaction to start? I was trying to think of a different word for start. Commence. There we go. What has to happen?
Is it when baby takes its first breath and
Yes.
that first, cry?
It not necessarily the cry. It doesn't, remember how we were talking about not all home birth babies do that big huge gasp and scream immediately. Okay, but as long as they make that respiratory attempt and you can see that like they're making respiratory efforts, because that cry, that big huge like ah, might not happen right away in home birth babies, but that doesn't mean that respiratory attempts aren't happening. Okay, so what's showing us respiratory attempts? Perfusion, they're starting to pink up. They don't look like a wet floppy noodle. There's tone. They have a good APGAR score. Okay, but it's the respiratory attempts, because then when the oxygen is hitting the lungs, that's starting and triggering and driving that chemical or that gas. It's gas chain reactions that's signaling to the umbilical cord to start and the placenta to only shunt blood to baby, and then that's what drives the bypasses to start to physiologically close up as they need to. Okay, so 2 physiological bypasses in the heart and 1 in the liver. Okay, Here's another picture of what's, okay, because this is the umbilical vein from the umbilicus to the liver that shuts off and dries up, right? That ductus venous. Okay, another picture, same thing, but another picture. Just because my brain learns it by lots of pictures of the same thing. I don't know. It must be one of my ADHD superpowers. Okay, but then
It
the
is.
time frame. Sorry.
I said it is a superpower.
Oh, right. But then what's the physiological time frame? Okay. The two heart bypasses are the top one, the liver one is the bottom one. Okay, so within hours, that middle one within several minutes after birth, that one's already closing up. Okay, the liver one within several minutes, it's already shriveling up. Right? The second one, I mean, that's 10 to 96 hours. And then that's very reflective of why the official CCHD and for most states too, and if you go by the state paperworks and when they want the CCH conducted, that's why they do the 48 hours, is because they want to know that those bypasses are physiologically appropriately shutting as there's need to. Okay. Any questions about this? Anything that you want to go over? Clear as mud? Okay, joking. Okay, so NBS and CCHD can cardiac congenital heart D. Wow. Auntie, what's the D? No, joking. Can't think of it. It's a congenital heart anomaly screening. Okay, so NBS, that's the heel stick card. This is the image on the right is the North Dakota one. Okay, so this is the one that the state wants me to give to every family and talk about all the reasons why everybody's tested or should. You don't have to. And then again, that's different for every state. So that's something that you might have to suss out with your state. You know, is there an opt-out? Why might a family consider opting out? Okay. And we'll go through this more, you know, this is an area, the hands-on skills will expand. We'll come back to this and expand. Okay. Is this something that you even want to do? Okay. Not every midwife wants to be able to do this for their families. Okay. Do you have that option to not provide it? Why might you not? You know, if this is an area to revisit about your state paperwork process, you know, I would encourage you to revisit this before the skills weekend when we revisit this again. Okay. This is the heel stick where they use the deeper lancet, and then that the blood spots are from the heel, and then there's 2 labs in the whole country that takes care. This is all that 2 labs in the whole country does is the newborn NBS. Okay. Is anybody familiar with their state's process for the NBS?
I have done these before.
I bet.
They're
I
not
bet.
very
Yeah.
it's so particular. You can't touch the circles at all, like on anything. And luckily I've had support from my preceptor on doing it. But it can be tricky, and we do have quite a few moms who decline it. So when we're doing the filling out the birth certificate, there's also a line on there for this. we have to put the number on it, and if they decline it or if they do it, but just to make sure that we provided it for them.
Yep.
But yeah, it's so, you know, they need the specific amount of blood to fill that hole. That's it doesn't look like a lot, but oh my goodness, it's really.
It has to be one fat drop. It has to dry evenly. You can't reapply it. You can't, it has to spread and all fill up the hole. And this is this is time specific. Okay? This has to be done at a very specific specific hours old of baby. I'm not going to tell you what that is because I'm going to encourage you to suss that out and bring it to the skills weekend. Also, every state, the states get to decide what tests they include. Some states is like, I think the lowest is like 9 and the highest is like 140 something that get tested from these 4 blood spots. Every state chooses different tests of what get included in their NBS. So there's another thing I'm going to encourage you to go down the rabbit hole and, you know, what are the tests that your state does? Okay? Because if families are asking and then the conversation about like, well, why, what are they testing? What, you know, why might I not do this? Most of my families opt out of this. Even though I do have a lab number, which is a little bit hilarious to me because I'm not recognized by the state as a care provider, but the state health department wants these tests done so much that they gave me my own lab number to do these tests. So, yep. So, little carryover assignment to the skills weekend. What's your state's NBS? Okay. Then the CCHD. So lots of states on their birth certificate, they want a pass fail of a CCHD. Are you required? Is there an opt out? You know, because it's a, oh shoot, I meant to grab mine. Can you go get mine from my prenatal bag? I know that's not super helpful. My CCHD. I don't remember now. That is super not helpful, Jane. Oh, you have, yeah, just hand me yours. So this is another thing that the state wanted me to do so much that they gave me this piece of equipment just so I can check pass fail on the state paperwork. So you know, if that's something that you can collaborate with your state's health department, that's a, you know, expensive piece of equipment that you don't have to buy for yourself. Yeah, see if there's a program available for that. And the unofficial CCHD, I do an unofficial one during the newborn exam because I want to know oxygen saturation. Oh, you know, what's it looking like? But then the official one, because they want to know, the whole point of this is, are those physiological bypasses closing up appropriately? And that's what this is testing, by testing baby's oxygen saturation. Oh, this is just an old one, an old muscle. Yeah, so, oh no, it's not, but basically looks the same as a Massimo. And then this goes on baby's foot. And it does the pulse and oxygen saturation. Any questions or thoughts about this? Again, not all midwives choose to provide this, even if it's required. You know, that would be another thing to revisit about your state paperwork. Can you opt out of this? When I didn't have the equipment, there's a box on mine that says not tested, or it used to say equipment broken, and then I wrote in too many times NA and then checked it, and then they started calling and I'm like, it's not broken, I just don't have it. So then that's part of the reason why they gave me the thing. It's causing too many problems at the state. Okay, any questions about NBS, CCHD? Okay, and then this is something that you will get hands-on. This will definitely be revisited in the hands-on skills. Okay. Eldon cards, blood typing. If you have somebody that doesn't know their blood type, and the conversation of RH negative comes, this is a pretty easy way. I was gonna say cheap, but I just ordered some new ones and they got expensive on Amazon. A lot of times, even if the mom knows, I do these a lot on dads, because if the mom knows she's RH negative and then she's freaking out thinking she has to get RhoGAM, I'm like, well, what's your husband's blood type? Well, I don't know. Well, why is that important? Okay, well, it's pretty important. So let's do it real quick, right? This is also something you can do from cord blood for baby. You can blood type baby, and if baby is RH negative, then that changes the RhoGAM conversation too. So can be very handy to have. I've typed siblings because she didn't get the RhoGAM, she didn't get the titers test. She doesn't know, but she wanted to know. But then we're talking about, I was like, well, do you know your child's blood type? Because if your first child was RH negative, then no matter what, you wouldn't have developed titers. Okay. Any questions, any thoughts? Just, me, throw it out. Okay. So, kind of jump the gun. Okay. So how does this drive, or be helpful to the RH negative and RhoGAM conversation? I gave you the answer a little bit. Somebody expand on the answer.
Can you say that one more time?
So how would having the Eldon card, how would that be helpful or influence or potentially change the RH negative conversation or the RhoGAM conversation?
For the parents or for the baby? For baby?
Either one.
Well, oh.
Yeah, either one.
I mean, for the parents, I think it's a great idea if dad doesn't know, to know, so that they know a little bit more about the risks, benefits, some informed choice about it all. And then for baby, after baby's born, I think that it's good to know, so that depending on if it's a first time mom, second time, depending on how many kids she had, to know, especially if their body is making antibodies.
Yep.
Especially hugely on like informed choice. Some of them just are like, no, I don't want to, but also just to give them a full informed, so that they can make their own decision.
Yep. Yeah, and I would say that that's probably the biggest benefit of having this tool, is because now they understand why this is important. They're, like you said, they're fully informed. They understand more about their care. They're making a much more autonomous decision for what they want to do. Yep. Okay. Newborn charting. Oh, this is where I meant to show you my newborn chart. Not before. But I will post that for you guys if you want to see it, or if you want to use it to develop your own. You can scribble my name out at the top and completely gangster it. It's fair game. I don't believe in reinventing the wheel. Okay. Okay, so Anything up until now? Anybody need a quick bathroom break? Coffee break? Anything? How are we doing?
Bathroom break.
Okay. 2 minutes or less. 3 minutes. Ready, go. Timing you, Shoshana. Ooh.
I was going in and out of service when we were talking about, or is Millicent still here?
I'm here.
Oh yeah. But I have that book, but I don't have the
The
card.
pocket. Okay, the pocket lessons.
Yeah.
Can you throw,
Okay.
if you could just mention in WhatsApp if you have one or the other or neither, because Auntie's gonna send out whatever books we need to get us all the way up until the skills weekend. Okay. Shoshana, let me know when you're back.
I'm here.
Okay, cool. Is anybody else step away? Can someone check in the, or let me know? I don't know. Everybody here? Okay, here we go. Keep going. Okay, so now we are taught this is physiological normal. Okay, so short cord cyanosis, birth bruising, birthmarks. We are still in what can this look like and still be physiological normal, right? So what is short cord cyanosis? Okay, well, a little bit lingering blueness in the hands and the feet. Baby has passed the CCHD, okay, but it's very obvious that baby had a tight short cord. They couldn't even pull it all the way up to mom's chest. He had a whole baby on the belly. Okay. Last couple contractions, they just get a little extra tight pull, and that physiological normal hypoxia just gets a little bit prolonged, and sometimes that can linger. So a little bit of blue lingering in the hands and the feet. Sometimes it can be around the mouth. Okay. But the key is they pass their CCHD, and it's noticeably dissipated or gone by the time you revisit baby at the 24 to 48 hour mark, and you noticeably noted there's a short cord. Okay. Now, if the cord, well, okay, so short cord could also be a nuchal cord where it's wrapped around baby, right? So a lot of the cord real estate got used up that way, you know, and that can shorten the functional distance between the last wrapped area and the placenta, so that tugs a little bit hard. Okay. But the key factors of how this can be still physiological normal, CCHD is passed, they pass the CCHD. And by your 24 to 48 hour checkup, it's gone or almost gone. Okay. And this can be a little bit lingering darkness of the face. Okay, it's not in the hands, it's not just but we're not worried about baby's tissue perfusion, right? We're saying that the CCHD is passed. It can look a little darker in melanated babies, okay? Can linger a little bit. Okay, birth bruising. Okay, look a little roughed up. Okay, very, very common with babies who are not completely flexed. If they have a little bit neutral face presentation, it's basically an abrasion rub between mom's tissues or bony processes and the face, because their head wasn't tucked all the way in. Right?
So like like maybe a slight bruise on their nose.
Yep, that's possible. Okay, little bit of swelling in the eyes, probably had when they were either extending and they really abrased against the vaginal wall. Okay. Okay. Can see between the eyes and on the tip of the nose, a little bit of tissue abrasion coming through. Okay. A little bit of bruising on the eyes, a little bit of the upper lip. This baby probably was not fully tucked in and had a short cord. Okay. What are we seeing here?
The red on the eyes, lids.
Mm-hmm. Yep, a little bit of tissue abrasion. Anything else? Now this could be the picture, but I'm going to call that bluing on the chin. A little bit of short cord cyanosis. And you can kind of see that there might have been some bluing on the lips. So then if there was at birth, but then this is either your 24 or 48 hour visit, and the swelling has gone down on the tissue abrasion on the eyes, and there's, you know, all the bluing on the lips is gone or almost gone. And then if that is bluing, I'm going to say it's bluing for my teaching point on the chin. You know, it's notably dissipated. Okay. There are options to support this if it's worrisome to mom. Physiologically, not going to harm baby in any way. Okay. If you choose to carry homeopathics, arnica, right? Bumps, bruises, arnica, safe to give baby. You can like crush up a little pellet and put it on the inside of their cheek. I don't personally like using essential oils on babies, but I do, you know, that's a possibility. If you decide to use oils in your practice, you know, making sure that it's a good appropriate carrier oil, appropriate ratio, only putting them on the bottom of the feet. Lavender is very gentle and it dissipates the bruising safely. Right. And then just another example. This is so baby's a little jaunty, so this is a new baby. Little bit, I mean, clear abrasion on the eyes, a little bit on the tip of the nose. Yeah. I would guess that baby probably was neutrally flexed, you know, not fully tucked in, and probably came around the posterior turn and maybe rubbed up against either the pubic arch or the ischial spines in a little bit of a funky way.
Almost like a pinch. You know how like you pinch your finger between something?
Yep. Yep. Hey. What are we seeing here?
Got lots of blue.
Yep, probably a short cord. Probably 37, maybe 38 weeks gestation. Some of the kind of rougher physiological tissue abrasions I've seen are like the 37, smaller 30, because they have more space to kind of bang around and they can navigate without fully tucking in. Those late gestational babies, those 9-pound babies that really 10-pound babies that really have to tuck in and like move around, you actually don't see a lot of tissue abrasion with those guys. You might see big capits, but usually don't see a lot of. I eat my words because my OP baby, my OP son, holy cats, he looked like he went through 10 rounds with Holyfield. He was all bruised up and yeah, but he's still a rough guy. Okay. Who wants to give this a stab?
Well, that's some definite bruising.
Yep.
Almost looks like a Mongolian mark on his face. His or her face.
Yeah.
Possibly. Little bit of bluing on the feet. Do you think that this could be short cord cyanosis?
I think so.
Okay. Could be. My first question would be, and this is, I'm not trying to be tricky with you guys, but my first question would be, was this a face presentation? Was baby's face pressed on the cervix for either all of birth or a portion of birth until baby was able to turn? Not saying that's what it is. I don't know. It's just a picture. I'm just saying like that's one of the things that I'm like, I wonder if this was a face presentation for some. Now, my best guess would be that baby did not birth face presented, because those are very drastically, when they completely crown face presentate, that's very drastic swelling. So, you know, mongoloid spot, that's a very reasonable question. You know, not to get into too many of the what ifs, but you know, this still looks like the potentiality of physiological normal, either short cord cyanosis or tissue abrasion of some kind. It
Can it
that
be
make-
both, or is it usually just one or the other?
It could be both. Yeah. Yep. Yeah, it could be both. Like, if baby had a complex nuchal cord, like around the neck, and then a nuchal hand, you know, so they're kind of like coming through kind of wonky, not fully through on their head. Yeah. Could be both. Biggest takeaway, this is not something that I would necessarily feel that needs to be transferred to monitor. You know, as long as you're seeing notably less swelling, less bruising, notable change at the 24-hour, definitely 48-hour mark, could still very well be in the realms of physiological normal. Hey, what about this one?
Looks like bruising a little bit, or a little, maybe abrasion of the eyes, the forehead, above the lips.
Hmm?
And it looks like a pretty chunky baby. So,
Yep. Nice filled out cheeks.
yeah.
Yep. What if I told you this that, you know, or okay, so you witnessed this baby, and you know that this baby came through fully flexed. Fully flexed. Could it still be tissue abrasion? Yep.
Looks more like birthmarks. Oh, could it?
Yep, potentially. Yeah. We could be starting to cross in the birthmark. Like, and time is the biggest factor. If there's no change and it still looks like this at the 48-hour and there's been no dissipation of color, you know, eyes don't look swollen. Okay. There's a potentiality that this could be, you know, stork bite, salmon stain, port wine stain. Okay. And then that's just the break. Okay. So now again, and this one I specifically looked for a salmon stain. Okay. So potentially not a huge, if I know that this, because I watched, this baby came through fully flexed in the OA, so not a lot of potentiality for abrasion on a bony process of the pubic bones. Okay, it could be a birthmark. Right. Right. Who knows what this one might be?
Strawberry. I call it a
Yep.
strawberry.
Yep. Stork bites, strawberry stains. Yep.
What a cutie.
Right. Okay. So of course, you know, if creating the potentially differentiating conversation with a first time mom, that's like, my baby's 4 days old, how come they're still so bruised up? Okay. And is this something that you would automatically refer out to a pediatrician for confirmation? Maybe. Okay. If the conversation alone isn't alleviating to the parents, potentially. Right. And of course, I mean, our reservation communities are well versed to the confusion of what's going on with this baby. Right? What's going on?
The blue spots, the Mongolian spots.
Yep.
That's like the biggest Mongolian I've ever seen.
Yeah, it is. It's quite extensive. Yeah, it is. Yep. But that's what it is. Yeah. Quite alarming. Yep. Is this, would you want to refer this family immediately? Would you want to monitor it? That's a really, there's no right or wrong answer, because like we're all familiar with the whole process. Like there's lots of healthcare providers that don't even know what the definition to that word. And it doesn't look that they literally just changed the name of it. Now I can't think about the name that they officially changed it to. Because the previous name wasn't PC enough, but whatever. I don't have opinions, guys. Okay, so that could be pretty precarious for some of the families in our tribal communities, right? Because what's the first thing that a lot of our border hospitals are gonna think?
Abuse.
Yeah.
I think of it like when you look at the picture of this baby, you see the little spot down there on the right side under his or her shoulders. You know, just the different markings. Some cultures would consider this, you know, very special in their beliefs.
Yep. Yep. And majority of the time, these dissipate. I mean, this one, there's probably going to be a lot of this that might not ever dissipate for them in their adulthood, or who knows, right? But yeah.
Natural tattoos.
Right? Yeah. Okay, go show mom. Yeah, go show mom. Okay. Anything that you want to revisit on any of that? Okay, we good? Good so far?
Can we just review the newborn exam one more time?
Sure, we sure can.
Mama.
Yep, go show mom.
Hey, Mama.
Is she in your class? Yep. Can you take her to mom?
Yeah.
Newborn exam.
Okay.
Yep,
Come on,
go ahead.
Mommy.
What are we doing?
Newborn exam. Miss Pearl wants to go back to newborn exam. Here, right? Okay.
Yes. Thank you.
Yep. So I just picked a different infograph than what I had used in last unit's lecture. Okay. Overall appearance, right? So APGAR plays into this too. At the bottom of mine, I have the 1, the 5, and then the 10-minute if I need it. It's not very common for me to do a 10-minute APGAR. Okay. There's no set, even in facilities, not all facilities do the same things or all of the things, or I mean the basics, height, length, weight, because that's the statistics that get passed to all the grandmas, right? So do you have anything specifically that you want to review about this, Pearl?
No, I just wanted to see these again.
And this might be the most extensive bulleted out list that I've seen, you know, but a lot of these is kind of just like an overall visual wellness check, right? Shape of the belly, like are you gonna sit there and like mold out the shape? No, but does this look like a healthy, I mean you could if you choose to, I'm not saying don't, but the overall, does this look like a healthy 41 week fat baby. Yeah. Okay. How do I zoom back out? Okay. Okay. Anything else about, and then this is about not all of the reflexes, but some of them. And we probably won't have a live baby to go through this, but we'll have my teaching babies, and I'll go through it just like I do with a live baby. Anything else? Okay. So let's see where we're at for time. Okay, not too bad. Placental examination and charting. Okay, kind of the same thing. Every midwife develops their own style. I do know midwives that don't do any placental examination. I think that's personally wackadoodle, but that's their style. Okay. Okay, because what are we looking for? Right? Well, an intact placenta. And how can and this is the part that I'm like, what do you mean you don't? No, I don't look at the placenta. I'm like, how do you know it's all out? Oh, I just give them the things. No matter what, I always just give them all this. And I'm like, okay, that's an approach. It's an approach. Yeah. This can be helpful in if there's a concern with gestational age, and how if you like went down the chart and gestationally aged the baby, like you thought by dates baby was 40 weeks, but baby comes out looking kind of like and then you go through the chart and you gestationally age the baby to 36 weeks by the points in that corner. My next step would be looking at the placenta. Okay, what does the placenta look like? Does it look like a nice fat cotyledons and fully perfused, and or is there some circumvallate? And we will have placentas at the skills. I've been stacking placentas. I got like 4 in the freezer. Okay, so you will have real placentas to look at and see all the things that we're pointing out. Okay, I forgot how wonderfully magical Auntie is, and that she was able to procure the placenta examination guide. I forgot you guys had that, so that's on me. There's a link here to a YouTube of midwifery, not in this country, of course, not in this country, but it's a nice video that talks about their facility, how they train their midwives to fully examine a placenta. The only thing that probably isn't applicable to us is their facility does take 3 samples, and then they talk about that. But otherwise, like, they do, it's a nice YouTube. It's only about 5.5 minutes long. So I wanted to include that too. For me, the biggest thing is like, on the maternal side, can I fold it? You kind of like fold it back on itself and make sure all the parts, the jigsaw matches. Okay, that's the most reliable indicator if there's any retained products. Oh my gosh, the worst. Okay. This is definitely an area that we are going to do some deep dives in the next, after the skills weekend, because when we talk about like SGA, IUGR, you'll see the difference in a beautiful, fat, chunky placenta that nourished a baby, and a placenta that was on the struggle bus and was barely holding on. Okay. Charting wise, you know, I'm happy to come up with a chart or like a chart paper. I don't do that anymore. I do make a note on the bottom of my newborn exam, saying that placenta examined and thought to be complete. Because for me, that's all I need at this point in my practice. Okay. I just want to make sure that I don't suspect any lingering tissues, either from the maternal surface or from the membranes. Any thoughts or questions? It's cool when we get to see really super chunky, healthy placentas, but they're kind of boring. They're gorgeous. And I don't mean that in like a slamming way at all, because it's a pretty amazing organ.
I always think of kidneys because the maternal side looks like kidney.
Yeah.
Makes me crave some kidney. Some salt. No.
Any thoughts or questions? Anything come up in the readings that you kind of trying to piece together or have reflections about? Hey, rolling on through. Okay, so common regulated standard operating procedures in regulated states. Okay, not talking about in facility, probably not going to be ever applicable to any of us, but in some regulated states, they do require you to either provide or do prophylactic eye ointment, vitamin K shots, Hep B shots. I am not aware of any regulated state that requires their midwives to do it that then don't have a reciprocating opt-out option. But there again, that would be a good thing to suss out if you're not sure about what your state requires. I think it's a good, even if you aren't really currently interested in being a DEM that operates with licensure, I think it's still valuable to know, to be a conversational resource about it too. Okay. Minor tears, so like perineal abrasions, first degree or less, right? Like a skid mark or I'm not talking like second degrees or anything like that. Okay, aftercare and charting. Okay, I don't check perineums automatically. Okay, I've developed to the point where we revisit the conversation after they go to the bathroom and after they shower. Okay, because if there isn't hot burning sensations, if there is anything, it's probably a little bit of an abrasion or something minor, you know. And some women don't want to be checked. That might be a previous experience that they don't want to go through again for whatever reason. Okay. I'm gonna stop that thought right there because the next thought was going to be talking about second degrees and beyond. We're not in that phase, Jane, right now. Physiological normal. Hey. 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 Any questions or thoughts about that? My preceptor checked everybody, and then you got another check at the end of care because she wanted to do an internal check, and you know squeezed your muscles, and she wanted to make sure that she could feel the difference with her fingers. That was her style. Care cleanup and instructions before leaving. We're still hey, go show mom. I usually do incorporate some cleanup because I'm usually looking for something to do in that first hour, because I have a really deep passion about undisturbed first hour of birth. So I'm usually looking for something to do. I'll probably do a little cleanup. Maybe start draining the pool. I will post the instruction sheet that I leave. We will talk about, you know, what does the instruction conversation, the last check-in conversation look like before you leave. What instructions do you want to leave for self-monitoring tone, uterine tone, and fundal height? Do you want to leave any? Right? Some moms, I do walk them through, what are you feeling for, because I'm gonna ask even before I return at the 48-hour mark. Usually there's an associated heavier bleed, or maybe prolonged pushing, or you know, 4-stage contractions just never really got super strong. Okay. I don't walk every woman through assessing her own tone. And I don't check every uterus tone before I leave. If she's very visually, you can tell she's latching baby and she's like, oh, these contractions. Oh my gosh, these contractions. I know that uterus is doing what I would expect it to do. Right. But you know, she took a shower, she ate, she latched baby on, and she's like, oh yeah, I don't really even feel any contractions. Like, no, I haven't had one the last 2 times. I'm like, can I take a quick check, please? Is it okay? Okay, so that's how my style has developed 14 years later. Okay. Same with postpartum after pain management. I really encourage to not use something like after ease or cramp bark for the first 48-ish hours, because we want those cramps to be, we need those. They're doing a job. If they're comfortable with a couple low doses of Tylenol, that's a safe option. If they're not, arnica is my go-to recommendation. It's actually something that comes in my birth kit. So when we talk about deciding what your birth kit looks like, in mine, there's a little dram of homeopathic arnica, beadlets, and oil. Okay. I've found out over the years that I have to be very, very clear about not using heating pads, because I could not figure out why she's still sending me all these pictures. She's like, oh yeah, I'm filling these pads, pad after pad after pad. And I'm like, okay, what else are you doing? Oh, well, the heating pad is taking care. Like, I haven't had any cramps, or it's not painful at all because I've kept my heating pad on me. And I'm like, okay, well, then that makes sense. It makes sense why you're filling pad after pad after pad. Like, you're encouraging your uterus to bleed. I think that belly wrapping, belly compression, support wear, either traditional belly wrapping practices or contemporary is an excellent first option. Any thoughts or questions so far?
I was just wondering if you would use fireweed at all. If you could use like for your little herbal or homeopathic stuff.
As a homeopathic or as an herb?
As a herb, I guess.
Okay. That's not one I'm personally familiar with. I would love to learn about it. Used in the immediate postpartum?
Yeah, either like the flower or the root, and it's like it's like sometimes it's been better than Tylenol, but I don't know. I've never used the root postpartum, so I was just wondering if maybe you had.
My first question would be, what's its action? If it's something like cramp bark that relaxes the uterine muscle, it might not be something that I would recommend in the first couple days. But if it's more like a Tylenol where it's a pain analgesic, but it's not a direct action on the uterus, because I still want, because sometimes I'm very far away, right? I'm hours away sometimes. Now, if it's somebody that I'm close to, where I can go and see before the 24-hour mark or very easily, my recommendations would probably be different. But a lot of times I'm only either getting text communications or pictures. So I take that into consideration when I'm making that 48 to 72 hour first 2-3 days recommendations. Okay. I'm not saying that herbs that have a uterine relaxing effect are horrible and you absolutely should never. Those aren't the go-tos for me because I can be so far away. Okay. That is not to say that I haven't made those recommendations with women who have a history of just absolutely over the top, toe curling, migraine inducing first couple days of, because that's too much, right? Like there's functional 4-stage contracting in the first couple days, and I mean, I'm not trying to say buckle down and bear it, but like they're productive, right? But if it's over the top, where like it's curling her over in pain and it's blinding lights behind her eyes because they're just like so relentless, and just like she can't hold her baby and she's barely even functional to take herself to the bathroom because those 4-stage contractions are just like literally curling her over worse than laboring contractions. Yeah, then I probably would start talking about after ease or cramp bark, or if that's an action that fireweed does, because that's too much, right?
A quick story. I just had a birth a little bit of, not today, but a while back, and she was having what seemed to be really bad after pains. First time mom, and when it got to like pushing stage, I had to almost take out my mom voice for pushing, because you know how they like to like tighten their butt cheeks and put their legs up and whatnot. Or not their legs, their butt. But then after all that, it was just so much, and we had her get transferred because of the pain. It was just not sure what it was, and she has a hematoma in her perineum, but deep somehow, and I don't know. I haven't got any updates or anything, because sometimes, when I'm not the primary, so when they go to another place, but I don't know. That was the first time I had dealt with that and thought to myself about the postpartum cramps. Like at first that's what it seemed like they were, but it got really strong really fast. Um
Hmm.
yeah. But when she was in labor and her water broke, she was on the end of the bed and like squatted down and then her water was like and I'm almost betting baby like dropped at that time maybe really I don't know but it's something it was just something different and reminds me of it was a whole different postpartum scene.
Yeah, I was actually wondering if there was like, I was like, I wonder if there was a trauma there or if there was like a previous trauma, like some sort of tissue
Mm.
something. That is interesting.
I have one.
Yeah.
So I was a doula for um, she was a social worker for a school district, and she and her husband have been trying to get pregnant for a really long time. Um, got a thorough history on her from the beginning, and she was very open about it. But she has had a history of um, I guess you want to call it a prolonged sexual trauma, and so we knew that, and we were kind of prepared. When we get to when I got to the hospital, she was, in a regular labor, but as the contractions got stronger and harder, um, it was too much for her. She was um, holding baby and clamping down, and um, the contractions were strong. It was just too much for her to bear, and she wanted a natural birth. She didn't want any medications or drugs, and all she could say is just, "I want to die. I want to die. I want to die. Just kill me." And it took so much to try to comfort and soothe her, and her husband couldn't. I mean, he was. I had to like push him to the back, but it was so hard just to sit there and talk to her and speak to her and and try to calm her down and change her frame of words. And I would um just change her frame. I would say, "You can do this. I can do this. I can do this. Baby's going to be here soon." All those things that you want to tell her. But because she clamped down, because she made things, not that she made them, but it was more difficult for her. um, she had a third-degree laceration. They stitched her up, and then she continued to bleed behind the stitching. Kept saying she kept saying, "It hurts so bad. It hurts. Why does it There's so much pressure. That hurts so bad." And she had delivered her placenta and everything. And I kept telling the doctor, "Something's wrong. Something's wrong." Um, and I think it had been such a long day. I went home. The next hospitalist came in, and they checked her, and they felt the hardness, behind. They went in and palpated. She let them palpate her, and they could feel the pooling of the hematoma behind the suture. So they literally had to go in and traumatize her some more, put her under, open her up, and clean her out. And yeah, it was a very whopper of a delivery. So yeah, there's a lot of trauma there. So get to know your families. That's just one thing, I've learned through doulaing, is like, make those connections, get to know them, gain their trust. And I think because of that, I was able to calm her down somewhat.
Yeah. Thanks for sharing. Anything else so far? I need to run to the bathroom quick. I should have did it earlier. Sorry. Okay, 2 minutes if anybody else. Okay, anybody else have to step away? Just my grandma bladder. Everybody still here?
Yep.
Okay, cool. Okay, so developing your postpartum checkups. Okay. Distance is can be a huge factor in deciding what postpartum schedule you want to come up with. Mine is 24 to 48 hours, and then a 1 week, a 3 week, and a 6 week. Okay. What assessments do you want to include with each? And what tools? What's in your postpartum bag? Okay. Do you recheck hemoglobin? Do you recheck baby's weight? What's another one? Well, if you do have a CCHD, do you just do it at the 48 hour? Do you do it again later? Okay. And we're gonna take a lot of time in the skills portion too, right? Revisit this, like what is each assessment tool? What is it telling you? What does it look like? Do you use it every time? Do you not use it every time? For myself, I've kind of developed into every mom, I do like to recheck hemoglobin at 1 week postpartum. But if there was a higher EBL, I might do it more than just that 1 week postpartum, right? Okay. The physiological hormone changes that are happening in the postpartum period, maybe that's part of what you consider about your checkup schedule, right? What's going on at the times that you choose to check in with them, right? And then how does that overlap with PPMAT or PPD concerns? And that's something that we'll get into more with the postpartum lecture next week. And then obviously that's one of the topics that we'll revisit. Pretty important one. Like, in the world of biology, the hormone shift that women go through in this postpartum period is most drastic hormone shifts in shits. Hormone shits. Sometimes it feels like your hormones are shitting. Sorry, Auntie. But it's the most drastic hormone shifts in any mammals. Yay us. Sorry. Okay. Normal bleeding. What does normal look like? You know, is this is definitely for me, because like I said, I can be hours away sometimes. I'm getting pictures and I'm sending pictures back, like this is what you should be seeing, or this what can be normal. I'm very diligent about send me a picture. It's not weird. I promise. I've been sent pictures of all kinds of stuff. But for myself, because I can be so far away, I'm very reiterative of send me a picture. When in doubt, send me a picture. Please send me a picture. Did you happen to take a picture of that? I would really like to see what's really going on. Right? It's not just because I'm a weirdo. Okay. What conversations or resources, what assessment tools do you incorporate for pelvic floor or diastasis recti assessment? Okay. Conversations about, you know, what do you ask about bowel movements and incontinence, and you know how their bathroom habits are going, or how their perineum feels. How does it feel to go to the bathroom? You know, are they still taking stool softeners? Has any pregnancy or labor constipation rectified itself? You know, how is that reflective of diet? Is there a potential herbal support that you might need to consider? Diastasis recti. I used to assess every woman at 6 weeks. Okay. Now I talk about it, and if they have a history of it, they usually initiate the conversation about it. If they have a lower BMI and other things aren't, like incontinence, constipation, lower back pain, posture, I'll still talk about it, but I might not assess. I might not assess by 6 weeks postpartum. Yeah. Any questions or thoughts? Okay, what instructions or recommendations do you want to recommend the starting of stool softeners? Again, I mean, I'm not trying to sound redundant, but I have worked with midwives, and I do midwives that they literally never have a conversation about bowel movement regularities and why it's important, or the first bowel movement, you know, how that can be very different. If they've never had a vaginal birth, either they're a first time birther or they've only ever had C-sections. Okay, and then they finally have a vaginal birth. That first bowel movement could be a pretty alarming process if they've never experienced it before.
I wonder, do you or could we, any of us, create like postpartum, not cheat sheet, but a postpartum sheet of for families, like what to expect or what to look for, or let me know if by day whatever X that I don't have a bowel movement, or this is what our lochia is going to look like on this day, you know, like a one pager or something.
Yeah. Yep. I have the conversation, and then I do leave an instruction sheet, and it literally is just the written version of everything that I talked about. Because having the written, even though we talked about it, and I wanted, you know, because I'm still assessing, is she back in her body? you know, is her cognition where it should be after having just had a baby at, you know, 6 hours postpartum. And then once the birth fog clears and they're like, what did you tell me about when should I be taking my temperature, or what should I be sending you pictures of? So yeah, I do leave an instruction sheet. I'm happy to post it. Yep. Yep. Okay. What was my thought here? Tissues, normal recovery. I remember. I think I might have covered that unintentionally. Any questions? Switch back. Any other questions or thoughts so far? Okay. If there was a little bit heavier of an EBL, a little bit higher of an EBL, or if she didn't handle a lower EBL well, I like to reiterate a few times about second day soreness. Like, you might be feeling really good right now, but on that second day, if you feel like you got hit by a Mack truck, it's probably because your body's finally catching up that you lost a bit of blood. You know, again, that's very reflective of me being hours away. I have to pack in a lot of information in that postpartum conversation, and then reiterate it at the 24/48 hour checkup, because then my next one is a week in person. I do a couple text check-ins, especially if there was something that to address or follow up on from the in-person 48-hour checkup. But a lot of times the next time I'm going to see her face to face is that 1 week. Switch, 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 switch. What is going on now? Nope. Huh. Apparently my tablet is over it too. Okay. Mother self-care, emotional check-ins, birth processing, reflecting, decompressing. Sometimes it's not about the birth that she just experienced. Okay, if it's a VBAC situation or first home birth versus after experiencing only hospital births, unexpected emotional processing could come up, you know, so that's something that I don't, because I support a very, well, I can support a very varied demographic. I approach this in different ways sometimes. Okay. There are some families that I support that are of a they're a type of Christian belief system that they don't even want to know that I contemplated that they had to have sex to make a baby. Okay. I'm going to approach this conversation and the next conversation a lot differently than with a mom who, you know, was sort of in active labor and was like already dropping all her clothes, and she's like, oh yeah, this is so much better, you know. So you'll develop your own style, and you'll develop how you may or may not approach it differently. If you're supporting in your own community, that might be a consideration too, because like depending on the community, like, or how your community dynamic is, if that's something that you want to take into account, not saying you have to, but if it could be a good reflective point. sometimes it's age. I might approach this very differently with an 18-year-old first-time mom than the 41-year-old 12th-time mom that I supported earlier this year. She's like, oh yeah, and then my labia was like, yeah, it like totally went down, and do you want to see it? And I'm like, no, if it's good for you, it's good for me. Like, I don't know. Sometimes it can be very, very very wildly different ways of approaching this topic and specifically this topic. Okay. Like I said, there's some factions of Christianity that I supported that, she wouldn't even take her dress off. Like, I'm not seeing anything above her knee. She doesn't even want you to even imagine the fact that her husband and her had to touch each other other than hold hands to like create a baby. And I might not approach this conversation with that couple, okay? Because their beliefs, that's not something that I'm going to be able to have a comfortable, appropriate, or functionally helpful conversation with someone of that belief system. Okay. A first time mom, I might spend a lot of time in this conversation because there can be a lot of it's a whole different body. My biggest takeaway is be kind to yourself, give yourself time, communicate with each other, discover what this body likes because that body likes something different. If it's like a ninth or a 10th time mom, what am I going to tell her about reestablishing intimacy that she clearly hasn't figured out in their dynamic? Probably nothing. Any thoughts?
So what you're suggesting is, of course, cultural awareness, community awareness, couple awareness, and letting her or them lead that conversation.
Yeah. Yep. I had a third time mom that I think it was the third week postpartum visit, and she just broke down and started crying, and she's like, I don't even want him to sit on the same couch as I do. I love him. I'm not mad at him. She's like, I just have no interest, like I can't even imagine that, it's gonna change for me in the next 3 to 4 weeks. So that conversation was very different than like it wasn't about contemplating reestablishing intimacy. It was about normalizing her hormones, were hyper focusing her brain to focus on baby. She still loved it. She's great dad. Like, she's not mad at him. I have no concerns about PMAD or P rage or throwing cast iron skillets at his head or anything. She's like, to me right now in my mind, his body, those man parts, she's like, he's like a Ken doll to me. Like, he's great and he's attractive, but like, I don't even think of him in that way right now. And I'm like, well, sounds normal to me. Sounds like your brain wants you to hyper focus on what you just spent the last 40 weeks and all these biological resources in creating. You sound normal to me. She's like, oh my gosh, really? You think so? And I was like, yeah, sounds like your body really wants you to bond with baby right now.
Mm-hmm.
But then at the right before our last 6 weeks visit, we were doing her last visit, and her partner walked out, and he's always looked nice dressed and hair is always in place. And as he was leaving for work, she she looked at him. She said to us, "Oh God, he looks so good." He said, "Stop, stop it right there." She goes, why does he have to look so good right now?"
Yeah.
So it's like, okay, she's got something on her mind.
Yeah. Yep. Her hormone shifted and like, okay, do you want to,
Yeah.
are you guys ready to have you had a conversation about, what do you guys, because, um, I, part of the thing that, not right now, my dear, um, with the women and the couples that it is culturally and dynamically appropriate for me to be having those conversations, one of the things that I always try to even remind multiple time moms is, because a lot of times they're like, oh yeah, my period doesn't come back for 6 months. Like, okay, but just because you're not menstruating doesn't mean you're not ovulating. Okay, so remember that when you guys are like winking at each other and ready to have some cuddles. Okay, now I'm not telling you what to do with that information. I'm not a part of that conversation, but please keep in mind. And if that doesn't bother you, it doesn't bother me. And if you would like to know, LH6, just because you're not menstruating doesn't mean you're not ovulating. Please keep that in mind for yourself, or don't. If it doesn't matter to you, doesn't matter to me.
I have a question.
Yeah.
So you were talking about the different beliefs and religions that you've supported. Is that like the community, or is that something that's on your intake form? Are these questions that you ask, like, like when you go to the hospital, they ask you what's your religious belief? And then
So
does
go
that
ahead.
cue you into, like, I grew up in the Catholic Church, so I know Catholic,
Mhm.
I don't know Mormon or all the other ones and what their protocols and beliefs are. So
Mhm.
then I guess I would just have to do some some internet sleuthing to figure it out, but is that like on your intake form, or these questions you ask at the beginning?
Nope, it's not on my intake form. So some of the belief systems, there's either something very telling in how they dress, how they carry themselves, things that they say, or something in their home. Okay, if I see something in their home, I'm like, okay, there's a very strong possibility that she's of this belief system. Okay. It could be their family name. For instance, there's the LeBarons. I know that they are polygamists from Mexico because of their last name. Okay, so I already know that, right? And that's not a slam or an assumptive thing. Like, that's where they're all come from, and they'll tell you that. Okay, so sometimes they just like, oh yeah, this, we're LeBaron, we're from LeBaron, Mexico. Yep, we grew up in the community. My dad's second wife is gonna come. My auntie mom, that's my dad's second wife, is gonna come and spend some time with me. Sometimes they're very, very open about it. Okay, sometimes I get insight because I'll ask, do you have any family practices or religious or cultural practices that you would like me to be aware of, that you want to incorporate in your labor? I will ask that. Sometimes that's an insight to the conversation. There are communities in our area that if I know that they're from that community, I know their belief system. Okay. I forget the belief. It's basically the Finnish version of Amish, and they have a very I know their community is in a specific area. I know that it's a few of the family last names. I know that if they have 6 kids and they're all under 7 and they're all bleach blonde hair, like white hair, they're probably of the Finnish community. And I know that no matter what I say, they're going to get pregnant every single year because that's their belief system. They're a quiverful practice, and for her to honor her husband appropriately, it is her duty to either successfully get pregnant every year or at least attempt to.
But you also might hear that she doesn't want to have another baby in that
That is
process
true.
too.
That is true. I have
been. We had that happen, and then like the same thing you said, where they're fully dressed, long gown, right down to the top of their foot. And I got to the birth first, and the lady said, "She's ready to push." And I said, "Okay, well, I don't have anything," because I was just helping. And the midwife came, and by that time she was ready. And I said, "Well, do you want to get up?" And she goes, "No, no, 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 don't, how did she say that? I don't need to do anything. You don't need to do anything for me right now, because I'm not gonna get undressed. I'm having my baby just like this." And that's and that's exactly what happened. She had her baby, and baby was born under her dress, and then we were able to see the baby after that. And then they named their baby right after that. The father named the baby. And they were from what is that community? Where is it at? By Oak Hills. Are those Mennonites? Mennonites?
Huguenots?
Yeah, Mennonite.
I think, yep, that's what they were. Yep.
I had a woman in the LeBaron community. She wanted to have a prenatal. It was like a kind of at a weird time. It was not like the usual. Usually she like wanted it in the evening. But she had asked me to just like, "Hey, do you have some time in the afternoon?" And I was like, "Yeah, sure." And I didn't think anything of it until she brought it up. She's like, "I wanted it in the afternoon because I didn't want my husband home when I say this to you." She's like, "I know that I cannot have another child as quickly in succession as this third baby. This is going to be her third baby in like 4.5 years." She's like, "Is there any resource that you can point to me where I could get on birth control that isn't going to go on the insurance? I can go by myself. I don't have to go all the time. Like, I don't have to tell my husband. They aren't going to call my husband. I don't need his approval." She's like, "I need a break." Okay. So even though I knew she was from that community, like that's the conversation that she was asking for too. So there are those types of situations too. Yep. If they grew up, okay, I've had clients who grew up Amish. Sorry, hold on. I didn't see you. If they grew up in a there might be a lot of conversations. They might have like literally like preteen conversations because they did not grow up with being able to ask those questions. Okay, so you're literally having like middle school sex ed conversations in your postpartum because they have no idea. Okay. Go show sister.
And for me, what worked best was just plain asking during our home visit and just being honest and just saying I wasn't aware of their practice and that they would have to help me along the way or give me some information. But that was the only thing that I could do because I didn't know anything about how their lifestyle. But I learned really fast that I had to stay out of their kitchen. Nobody was to be in their kitchen. And nobody could touch any of the kitchen items, anything. So it's just best to ask, I think.
Yep. Postpartum charting. Okay. I have a different form for everyone. Okay. I have a 48-hour one, a 1-week one, 3 and a 6 because there's my documents. Okay. Okay, 48 hours. These are now, do I do every single one of these every single time? No. Nope, not with every single mom. Okay. But if I want those pieces of information, this is the one I pull out and then I, fill it out as I go and then I just staple it right in the chart. Right. Oops. And then I had where I just pulled it up because I wanted to make sure that it was close. But anyway, same with, oh, here, 1 week. Hello. Just look, Jane. Okay. There's a lot of the same. Okay. I think this one might have a little bit more on, oh yeah, here, this one has a revisit on some newborn things. Okay. So if I'm reassessing weight, wet diapers, number of messy diapers, okay, things that they're starting to notice. I want to, and then checking the cord, any resources that they've asked for, because probably going to be different than the 48-hour checkup. So, yeah. And then nutrition supplements and teas, tinctures. I know I keep telling you guys this, we will be doing deeper dives in the skills weekend. And then when we're still in the physiological normal, right? So with the intention of physiological normal, protein is a perfect world. And not that I'm trying to say like, oh, we have to live in this fantasies of perfects or anything like that. But looking at supportive herbs. Okay, so are you re-recommending or continuing blood builder support, nutritive support versus corrective or corrective support? That's not really the word that I'm looking for. What kind? It might be. Maybe it is.
It is.
Oh, cool. Does that make sense? Okay, so we're still talking about for me the big conversation is you actually need more protein. I know you're sick of me saying it. I told you you're gonna hate that word coming out of my mouth, so you can't say I didn't tell you. But now you're feeding your body to recover from labor. Okay, you're feeding your body to recover from pregnancy because that is not one and the same that our body is recovering from. Right, our organs are shifting, our muscles are a little bit atrophied and then a little bit sore. And now you're eating to still grow a whole human, but now that whole human is on the outside of you and now you're lactating. Okay, so for me, and a lot of it is because I'm so far away, and I don't mean to keep harboring on that, but for me, that is a huge concern, or not a concern, a huge consideration. Okay, so I really tried to create deep and dynamic conversations of all the different aspects that you're still healing from. And you're not just eating because you're hungry. It takes 2 years for your brain to recover from being pregnant and labor, and you're lactating, and all these normal hormone shifts that are going on, and I'm really trying to break through that social conditioning of, we'll bounce right back. Don't gain too much weight. You'll lose it all breastfeeding and all those fun isms from mainstream cultural influences. You can tell I'm a little opinionated and I'm trying to find nice words, keep finding it. Hey. We're almost there, guys. Okay, so case study review. Really quick. I thought you all did a fantastic job. Like, really great. Really great. Not in the sense that I think that you guys missed this, okay, but in the sense of like correlating little details. So in the first one, and again, not that any of the recommendations were wrong or like totally off course, okay. Baby size, right? This is a 6 pound, 6.5 or 6 pound, 13 ounce baby. Might have not have got a deep, long stretch. Maybe restitution. Maybe you didn't see a lot of postural drainage. Okay. And again, not that any recommendation that you made would have been bad for that consideration. Just like helping your brain fine tune, filtering all the details and idiosyncrasies. One of the aspects of the conversation that I like to create is babies' muscles are learning the sense of gravity. Okay, those muscles literally have to get used to the whole sensation of gravity. And sometimes that means it takes them a little bit to cough up or drain out those last few little loogies. Okay. Case study number 2, the timeline. So you hadn't yet done the 48-hour checkup with the second case study. So, and again, not that any of the recommendations are wrong. I super appreciated the recommendations of revisiting, addressing a deep latch. I really loved how encouraging you guys were, how normalizing, you know, how like it was genuinely awesome. Again, the only little connecting the little lines, you hadn't yet done the 48-hour checkup. So nipple hypersensitivity can be from that postpartum hormonal shift. Okay. Yes, it might be, it's always great to reassess, revisit latch. But in that, especially that 24 to 48-hour window, that hypersensitivity, like, and cluster, like all the great aspects of you guys talking about normal cluster feeding and bonding and, you know, truly beautiful, all the things that you guys talked about. But again, just like connecting the little dots to the time frames. Okay, she's got a huge hormone dump, and sometimes that hormone dump, even if latch is perfect and that can create kind of that burning nipple, like what can be associated with shallow latch, tight ties. It could be just a normal hormone shift in that time frame. Okay. Any questions? Anybody want to share their thoughts or some of the things that they talked about? I mean, on really really great stuff, guys. I'm super impressed with how you all approached it.
And I appreciate how hard you work to offer up real case studies from real experiences and do that in a composite manner that, you know, protects client confidentiality. I think that's a gift to your students.
Oh, thanks. Okay, so what's next? Next week, same time, same location, postpartum doula lecture. Then unit 11 will get posted shortly thereafter, and then unit 56 starts on 9/1 that Monday. Okay. Unit 11 is 4 weeks, unit 12 is 2 weeks, and then we will be up to skills that'll take us right up perfectly. It totally is coincidence. I literally didn't count it out until recently, and I was like, oh my gosh, it fit perfectly. So, so yeah, we're making great time. We're right on track. I appreciate you guys, appreciate your hard work, appreciate getting through the reading lists. It's like, you know, perfect pilot cohort, basically.
Look at that picture.
Okay. Anybody? Anything for anybody?
I was actually listening to a podcast today on breastfeeding or postpartum. I think they were from Australia or New Zealand. They had that accent. But it was midwives talking. One was a midwife, one was like the show host, talking about postpartum breastfeeding, the normals, and they were kind of sharing like that day 3 is really when the milk transitions, is when typically they see moms have a hard time because they're like very emotional. Their hormones are drastically shifting. And that's the time to kind of check on them. Maybe that's a text message or a call or just to see how things are going because they might not realize that it's just like a hormonal shift that they're experiencing versus like these other thoughts that they have. And so I was like, oh yeah, that makes sense. With lactation and how the body is preparing and transitioning the colostrum to the more mature milk. That kind of makes sense that some of these other hormones that are a part of that really just change around day 3. So yeah, I was like, oh yeah, and then so I started piecing together some of the things that we had to read and just talking also about um mom I helped what kind of been meeting with her for over a year, and having some of the conversations like we brought up today about you know uh family planning or reestablishing intimacy, and oh my period came back, and I'm still breastfeeding, and like what's going on with my body, I'm like leaking everywhere, and having some just really honest conversations and education about kind of what's going on with her body, different options for like contraceptive, and thinking about, how that might impact breastfeeding. I think those are all helpful things, and, just having some resources available. So I always kind of like look for new things and things that are credible because there's so many things out there on like TikTok or social media or influencers are saying, and it's not true. Like don't eat Oreos to increase your milk supply. Like eat the Oreo because you want to eat the Oreo. Um, yeah, and so I think being able to, understand some of this physiology to share with families really helps them like, okay, this is what's going on with me. And then they can make the decision, like, these are my choices and options I have. So that's what I've noticed is helpful, is just kind of sharing the information and um, yeah, sharing information and resources so that families can um, feel confident in whatever they're choosing to do.
That's beautiful share.
Thank you. Appreciate that. Okay, you can have my pen. Holy cow. I guess I'm done because he took my pen.
What's the name of the podcast, Pearl?
I'll have to share it in the WhatsApp. I don't remember offhand.
Okay. Thank you. I started listening to a podcast from the Indigenous Midwifery I forget the whole name of it.
No.
Oh, Center for Indigenous Midwifery, their podcast.
Mm-hmm.
It's pretty good.
Yeah. Okay. Anything else tonight, guys? Okay. Wait to go Stade. Thank you for your time. Thank you for the sacrifice of your mind and your emotions, and thank you for receiving and my chaotic lectures. Got through another one. I don't know. Okay. Appreciate you guys. Good night.
My husband said he saved money on car insurance. The peanut gallery behind me. Have a good night.
Good night.
Night. Oh, I